welcome to a Tuesday edition of CPS VMR. Just want to just welcome everybody that's coming in today to participate in discussion of a case. And before we get underway, I just want to throw out there, if anybody has a case, if you can unmute your mic and just let us know a little bit about yourself. And if you do have a case, if you're able to present, just let us know. But before we, I guess I'll just stay muted for a bit to see if anybody would like to present a case. Deborah, how was your workout this morning?
Hi, everyone. I was just telling the team that I just got back from workout. It was terrible. Sometimes when I'm doing exercise, I say, why am I doing this to myself? But then in the end, it feels good. So, so yeah.
Yeah, so Madalena did a marathon. I was like, oh my gosh.
Yeah. I think I would put on my list of things to do, run the New York Marathon. Let's see.
Yeah, it's a great tour through all the neighborhoods in New York. So you'll get to sightsee at the same time and also participate in the marathon. So definitely a great way to get around New York. They closed down a lot of the avenues so you can run. Usually it's full of cars and the traffic is tremendous. Sammy, how's your day going?
I'm doing fine. I'm currently in psychiatry rotation, and yeah, it's quite interesting, but also quite humbling. Those diseases, how you treat them, and a lot of like speech therapy or like behavioral therapy and group therapy. So I was part of those today, and yeah, it was quite interesting to see that.
Absolutely, absolutely. Yeah, psychiatry was very interesting for me as well when I did that rotation. Yasmin, how's your day going?
I'm very good. Thanks for asking. I am preparing for my next week's step. And yeah, like I already got my permit to work here, permanent resident. So I'm very happy to start with all this journey.
Excellent, excellent. Yeah, good luck on your exam next week. I'm sure you're super prepared for that examination. So if nobody has a case, I'm going to ask Deborah if you're able to jump in and share the case that you have. And then I invite all the crowd to just type in the chat and also share your thoughts. So we have a small group, so we could do a group effort to try and get to the bottom of this case that Deborah has for us. So Deborah?
Yeah, I wait for the whiteboard. It is a 6-year-old male that presents with dyspnea. And the patient said that he has this dyspnea for 2 weeks and have been more progressive.
Okay, well, I guess we'll stop right there. Anybody have any ideas? I guess we're going to prioritize dyspnea here, specifically for 2 weeks. So I'll mute for a moment and see if the crowd has any thoughts. I see Mona in the crowd. Mona, one of my exemplary students. Mona, are you able to unmute your mic and share what you're
Yes, good morning. Good morning.
How are you?
Good, thank you. I'm doing OB right now in Chicago.
Oh, awesome, awesome. Yeah,
yes.
you did a spectacular job here in medicine.
Thank you.
So great to see you coming on and learning medicine through VMR.
Yes, I'm really enjoying my time here. It's wonderful putting things together and like finally reach the diagnosis.
So what do you think about this case of dyspnea?
So a 6-year-old male with 2 weeks of dyspnea, and it's progressive, of course. For me, this age is either COPD or asthma. I need to know more about the course of the disease, like temperature and like his body fluid status, if he's accumulating any fluid, could be cardiac disease. So dyspnea could be either cardiac or lung, pulmonary. Other than that, could be infectious. And this is my idea of approaching dyspnea.
Those are some really good thoughts there, Mona. I absolutely agree. Yeah, with some more information, which could be the past medical history, we may prioritize that, and that could help us to identify possibly what could be going on behind the scenes causing this dyspnea. Because right now, dyspnea could be any number of things. So I really don't want to do or put in a lot of cognitive energy trying to figure out at this stage. But before we even get underway, we have to make sure is the patient safe. So want to make sure that the airway is protected, the patient is breathing, the patient's circulation or circulatory status is appropriate. So we do need this data to make sure that the patient is in jeopardy or potential crisis. I think Nikita has some good thoughts there as well. Are you able to unmute your mic and share some of your thoughts?
I think he can unmute.
Oh, okay.
Right.
No worries. So I'll just read what she mentioned. It could be cardiac or respiratory. So yeah, what's interesting is with dyspnea, two of the organs that are responsible for oxygenation or air exchange or gases exchange is the heart and the lungs. So we do tend to think about these two organs, but there could be other non-cardiac or non-pulmonary causes of asthma, which we also may have to include. But again, as we obtain more data, we may then move towards or prioritize those systems when thinking about dyspnea. And I love what Jack mentioned. So POCUS solves 90% of dyspnea and labs the rest. So definitely, as we've done some POCUS VMRs, if you do put an ultrasound probe on the lung and you see B lines, especially B lines on both sides of the chest, this could be either interstitial pulmonary fibrosis, ARDS, could be pneumonia, could be congestive heart failure. So the clinical context of the presentation may help you identify which one of those four processes could explain those abnormal B lines. If you see A lines, then you may move away from the lung and start thinking of other causes of non-pulmonary causes of dyspnea. You look at the heart too. If the heart shows increased right ventricular pressures or increased right ventricular size, or when you look at the parasternal short axis, and as Dan Restrepo mentioned, usually the right ventricle looks like a croissant and the left ventricle looks like a bagel. When you have a figure of 8, or you see that croissant move to a bagel donut-like structure, and there's also flattening of the septum, this could indicate increased right-sided pressures, which could bring in the possibility of acute pulmonary embolism. So something to think about when facing a patient with dyspnea. Back to you, Deborah.
Great discussion. We made the POCUS case. And so the patient said that had some cough with white sputum, and said that he having fever, but he didn't measure at home, and from Malaysia that had started 2 weeks too.
Are you going to stop there?
No,
Okay.
I'm just waiting
Okay.
for describing.
No
He
problem.
does not present leg sweating, orthopnea, or nocturnal dyspnea. And social history, he works in an office. He doesn't smoke or use drugs. And not having traveled outside of Texas. It's married and no risk for sexual behavior. Medication. The patient presents atrial fibrillation, heart failure, and take the medications it's Rivaroxaban, lisinopril, furosemide, amiodarone, and metoprolol. And 1 week before, the patient had gone to the hospital and had started amoxicillin, clavulanate, benzonatate, and albuterol, and didn't improve the symptoms. I think I can stop here or go for the physical exam.
Yeah, I think we could stop here. It's very interesting how this information may help us move in one of a few directions, but I'll mute for a second and see if anybody has any ideas. So what I kind of would look at is the expansion on the HPI, the past history, the meds, and social history, and how they move the needle away from certain number of things that we discussed, and maybe move the needle towards a number of things that we were initially entertaining. Sammy, you have a gold mine of some comments there. Are you able to unmute and share some of your thoughts? You always have some wonderful thoughts there.
Yeah, sure. That's something I learned from Ravi, and I really try to also integrate into workup for patients, or when I take a history. When I have a dyspnea, ask for questions. Do they have any signs of inflammation? For example, if they have a fever, if they have chills, rigors, malaise, etc. This would point us more towards like a pulmonary cause, although you can have inflammatory cardiac causes of dyspnea, for example, myocarditis, endocarditis, pericarditis. Are there any signs of volume overload, which would make us more think about like the cardiac cause? And then also, are there signs of syncope or pre-syncope, which would prioritize a cardiac cause, or also a pulmonary vascular cause, for example, pulmonary hypertension or PE? So those are some things to ask. I think I forgot one, by the way. I don't remember.
Oh, that's enough there. That's a gold mine of thoughts there. And I may have to tap your Evernote or your Glass Health notes to get some of those Robbie quotes from you. But yeah, what Deborah's mentioned here are a couple of things that stuck out or stood out to me. Robbie's like nailed it. So there you go. Good job. So there's this cough. So we take dyspnea and cough with white phlegm. So, we always think about purulence of phlegm indicating maybe a bacterial infection. White phlegm could also indicate inflammation. But at this point, I think it's non-specific. But if I take the cough and I associate it with one of the medications, lisinopril comes to mind. And I'm not sure when the lisinopril was started, but you can develop ACE inhibitor-induced cough from weeks into months. So it's one of those things where you can develop a very serious nagging cough, can be debilitating. So we tend to then maybe take off the lisinopril, maybe switch it to an ARB agent in that case. There's no leg swelling, no orthopnea, P&D. Does this necessarily rule out heart failure? So like you had mentioned, does a patient have signs or symptoms consistent with congestive heart failure? But if you think about the definition of heart failure doesn't mean pulmonary congestion. It just means inability of the heart to deliver blood flow to all the organs so that they can metabolically function adequately. So you can have congestive heart failure without pulmonary edema and all of these other findings. There's history of antibiotic use, and there's also a antitussive agent, an albuterol, and there's been no improvement. So we thought about, could this be COPD exacerbation? Could this be asthma? Could this be a bronchoconstrictive process, but there's been no improvement with albuterol. The patient has taken a good antibiotic, which has good coverage for community-acquired pneumonia, and there's been no improvement. So is this a pneumonia? Unless it's there's a bacterial cause, viral cause, fungal cause, which isn't covered by amoxicillin clavulinate in that case. Do we have to think about drug reactions? Most definitely. So any of these medications can cause pulmonary related disorders. Anything jump out? If you review the meds, we've had cases of this before in VMR. Yes, Dania, very good. Amiodarone. So amiodarone can induce interstitial fibrosis. Yes, Rebecca, yep. Amiodarone induced pulmonary toxicity. So that is very suspect, and I definitely will prioritize that and track it. Metoprolol, unlikely. Lasix patient, we don't know if they're compliant with Lasix. And again, we don't see in the HPI any signal of congestive heart failure, leg swelling, orthopnea, and PND. So the amiodarone, definitely we're going to prioritize and consider it doing the workup of this diagnosis. The social history works in our office, no travel, so likely something that the patient picked up along their travels or outside the US. And no history of smoking or drug use. Does that necessarily rule out COPD? COPD could be acquired by many other causes, but smoking, you would start to consider some chronic long-term respiratory disease. Deborah, you want to continue on with the next aliquot?
Yeah, going for the vital signs, we have the temperature of 90, the heart rate of 90, and the saturation 80 on room air. The patient appears mildly well, a little tachypneic. The heart regular, the heart without murmurs. The legs with bilateral stasis pigmentation, but no edema, and skin and joints was all normal. And the lungs, crackles at the bases.
Do we have a respiratory? Do we have a respiratory rate and blood pressure?
No, I don't have.
Okay, no worries, no worries.
Sorry.
That's okay.
And going for the laboratory, the white blood cells was 70.5, was predominant neutrophilic and not eosinophilic. The hemoglobin was normal, platelets normal. What else? Sodium, everything okay. Creatinine 0.9. ALT 100. Diagnostic, no, 17. I guess I said wrong, sorry. White blood cells of 17.5. And BNP troponin normal. TSH normal. The urinary analysis was normal. Yeah, that's what I have. I can go for the CT chest or no?
Yeah, let's hold that for a second and see
Okay.
if this helps us in our journey through the diagnostic realm with the exam and the laboratory data. I think Jack is asking, was it JVD? I don't think there was peripheral edema, Jack, but there was signs of stasis dermatitis, I think, right, Deborah?
Yeah.
Okay.
JVD, let me see.
and the white cell count is 17, not 70. So Mona, are you able to unmute and share your thoughts regarding the pulmonary examination?
Yes, of course. So for me, I think when I see basal crackles is always pulmonary congestion, but that would not always exclude pneumonia. But like pulmonary congestion, mostly cardiac cause, and given the fact that he is having heart failure and atrial fibrillation, my thoughts goes more towards cardiac reason than even though his temperature is 99, his YBC is 17, but I feel he's more cardiac. Or it could be pulmonary since he have dyspnea for 2 weeks, but in the ground of already known heart failure, so the crackle is there for a long time and does not relate to the dyspnea right now.
Yeah, absolutely. I love those thoughts. This bilateral crackles at the bases, definitely we associate that immediately with likely pulmonary congestion. Congestion could be any number of things. Is it water? Is it purulence cells? Is it hemorrhage? Patient is on rivaroxaban, so pulmonary hemorrhage could be considered as well. But I would look for signs of hemoptysis when somebody has bleeding into the lungs. But a bilateral basilar process, there could be any number of things. So atelectasis is one of the things that could present with this. Could this also be a fibrotic picture as well? Could there be fibrosis starting at the bases? Could there be emphysema at the lungs? Alpha-1 antitrypsin deficiency can manifest at the bases. So a couple of things that may occur or originate at the bases of the lungs. Pleural effusions, unlikely having breath sounds at the lungs. So usually you'll have lack of breath sounds, maybe some atelectasis, compression atelectasis above the pleural effusion. So if you do examine the lungs, you'll hear dullness to percussion, lack of breath sounds, which we're not seeing here in this examination. And then Deborah mentioned there's no edema, but there's signs of stasis dermatitis. So this patient probably had edema of the lungs previously, but now is likely resolved. So the edema has regressed. So I'm not seeing signs or symptoms of congestive heart failure here, but definitely something that's screaming pulmonary. If you look at the vital signs, 88% of Romaire. So any baseline, Deborah, as far as oxygenation prior to this?
No.
So the 88%
Sure.
on Romaire is fairly new and is traveling along with this dyspnea for 2 weeks. So the patient is definitely hypoxemic. Heart rate is 90. Was he in AFib or was he in sinus rhythm?
Normal sinus rhythm.
Okay, he's in normal sinus rhythm, but the heart is working quite hard. And like Mona had mentioned, the temperature, sorry, the temperature is 99.4. So there is some inflammation, low-grade temperature, but it may not indicate that there's a pneumonia that may be taking place in the lungs. Looking at the labs, you have white count 17.5 with the neutrophil predominance. This could indicate a bacterial infection, a pyogenic infection. But again, I'm waiting for a curveball from Deborah. I don't want to yet get on board with a bacterial pneumonia, but this does make it highly suspicious. Jack is mentioning, are you able to unmute, Jack, and share your thoughts? Okay, that's okay. You're in a loud coffee shop, but I'll just read off what you mentioned. Could be a false low temp if the patient's tachypnic and taking an oral temperature. So that can definitely be a thought there. And the AST-ALT being elevated in the hundreds, is this significant? I really can't tell. Could it be drug related? I'm not sure. Amiodarone can induce a pretty severe liver injury, but could there be mild liver enzyme elevation? Not sure, but I'm not sure if this helps our cause or not, but we'll definitely keep that in mind and track it. But I would be interested in the imaging, specifically X-ray, CT. to see what's going on in the bases. Maybe the answer lies in the bases.
Okay, so the CT showed diffuse patch alveolar and reticular nodular opacities. Mild peribronchial wall thickening, no bronchiectasis, no honeycombing. And then was other rheumatologic lab, RF, CCP, ANA, INCA, and they were all negative.
Are we stopping there?
No, and one more. And then had done test of mycobacteria and fungal cultures, and they were all negative. Okay, in the next one, I will tell the diagnosis.
Oh, this gets very interesting now. So CT is showing a number of findings. I'll mute for a couple of seconds, and see if anybody has any ideas or any thoughts that they can share. I'll call on my good friend there, Mona, and ask what she's thinking.
Thank you for calling me that. But like diffuse patchy alveolar with reticular nodular opacity, I think this could be emphysema. I'm not sure though.
Oh, no worries. I think, to me, if you think about it, how about this? These findings are in the alveolar. They have this sort of patchiness about them. So there are a couple of different ways of describing opacity. So it is an opacity, but it is a sort of in a sparsely diffuse manner. A pneumonia would be a sort of may take up a section of the lung. So it may be a nice, what would I call it? Just a lobar pattern. But here it's diffusely bilateral, patchy. Ground glass would also be even more sparsely present. So we're looking at a number of things. What comes to mind is, like you had mentioned, could this be a chronic lung disease?
Is he? I'm sorry. Is he immune depressant that could be pneumonia Jurevecki with the diffuse pattern of?
Very good, very good. So now, considering that, yeah, what could present with a diffusely patchy process like this? Infections come to mind, and one of the ones that we do learn in school is PJP. So you have to consider, could this patient be immunocompromised? I don't see anything that could indicate that he's immunocompromised, but
I don't see that either.
But like, unless he's on steroids or he does have a immunocompromised or immunodeficient condition. But this could open the door to other infections, if you think about right, other pneumonias, mainly bacterial pneumonias. There may be some that may be diffuse, bilateral, patchy. There could be, namely, viral pneumonias that you may think about. So viral pneumonia is actually more common than bacterial pneumonias if you think about it. But the predominantly pneumonias that we do see in the hospital, like during your rotation, that you see are bacterial. But with the elevated white count, neutrophil predominance, I do think we do have a pyogenic infection here. So any number of bacterial pneumonias may be at play here. So from the most common pneumococcal pneumonia, Staph aureus, it could be Haemophilus influenza, Legionella, chlamydia pneumonia. So those are the more common sort of pneumonias. Do we have to think about fungal infections? I think less likely here, but those are a few of the things that I'm thinking at this time. There's no bronchiectasis, so there's not been a lot of or long-standing injury or chronic inflammation to the lungs here, and no honeycombing that may be associated with chronic lung fibrosis or interstitial pulmonary fibrosis or something like idiopathic pulmonary fibrosis. So I do think we're dealing with an acute bacterial infection here, and we'll see what Deborah may have to say about it in the next aliquot.
Great job, everyone. So the patient had done a bronchoscopy and had present a wavy fluid, white blood cells of 123. There was a macrophage of 84%, lymphocytes 5%, 10% neutrophil, and 1% eosinophil. I will put in the whiteboard. And then stains for microorganisms were all negative. And oil red O stain highlighted abundant lipid-laden macrophage. So the patient was diagnosed with the amiodarone pulmonary toxicity, and he had using, I jumped this information, but he had been using 200 milligrams a day, and it was not clear why was prescribed such a high dose. And then the patient stopped the drug and had the improvement of the symptoms with prednisone, and had a resolution of the hypoxemia. And some teaching pearl that I saw about the amiodarone that can cause like interstitial and alveolar pulmonitis and a diffuser alveolar hemorrhage and pulmonary nodules. And more than dyspnea and cough, half of the patient can present with fever, malaise, and most of the cases occur when patients are taking more than 400 milligrams a day for more than 2 months. So yeah, and as a diagnosis, it's an exclusion because the CT and the findings pathognomonics are the same for infectious and autoinflammatory disease. So yeah, that's the case.
Oh wow, we did sort of think about it at the get-go, but as you gave more information, it started looking very much like this is a bacterial infection, most likely. But you know, it's interesting, like it can just be this sort of indolent thing that just slowly creeps up, and then patients suddenly become symptomatic. So this probably didn't happen overnight, but he was starting to feel symptoms and maybe compensating with it, and then finally it came to a severe dyspnea for this patient, and then brought the patient in. So you're absolutely right. Yeah, inflammation. We should have revisited this, and from the get-go, we did consider some of these meds to be suspect. And again, a great case of amiodarone-induced lung pulmonary toxicity. So thank you, Deborah, for that great case. Sammy, could you proceed with the teaching points? Thanks.
Yeah, sure. Thank you so much. What a great case. Thank you, Deborah, and great discussion by everyone in the chat. And Ravi, thank you so much for facilitating. So we had this chief complaint of dyspnea, which makes us always think about cardiopulmonary causes before others, like the vast majority of dyspnea is caused by cardiopulmonary disease, for example, pneumonia, cardiac disease, pulmonary embolism, etc., versus others, for example, blood. I think about the 2 A's, anemia and acidosis, but also anxiety, neuromuscular disease, and thyrotoxicosis can cause dyspnea. Then we talked shortly about POCUS, which I've gotten a huge fan in the last month about, and it's really helpful, and it's really the future of emergency medicine, and it really can help evaluate dyspnea. We can put the probe on the lungs, and typically you would be expecting A lines, which is like a reverberation artifact, And when you see B lines, it makes you think about like an interstitial syndrome, that something is filling up the interstitium or the alveoli, and then we come to our broad differential about pus, blood, water, etc. Then we can put the probe at the heart and check the systolic, diastolic function. What's the chamber size? What are the valves doing? Is there any pericardial disease? And can also put the probe on the inferior vena cava to check for a fluid overload or congestion. Then we talked about questions to ask when someone has dyspnea. Is it associated with fever or an inflammatory signature, which makes a pulmonary cause or prioritizes a pulmonary cause, versus when there are signs or symptoms of volume overload, syncope or pre-syncope, which prioritizes a cardiac cause. Then we had lung crackles, which we can think about in dry and wet. When they are more on the drier side, we can think about atelectasis or fibrosis, versus when it's more of a wet, we can think about alveolar fillings, for example, seen in pneumonias, pulmonary edema, or also alveolar hemorrhage. Then we had this finding of hypoxemia, where we should always think about the 5 pathophysiologic causes, which are not always isolated, but can overlap. For example, low inspiratory ratio of oxygen. If someone is hypoventilating, is there VQ mismatch? Is there diffusion restriction? Or is there a shunt or dyshemoglobinemia happening? Then we had this interesting finding of diffuse bilateral opacities, which made us think about some typical infections that involve the lung. Typically bacterial would be strep pneumonia, H. influenza, chlamydia, mycoplasma, Legionella, staph, Coxiella. For viral, which is much more common, ravitolas, we should think about influenza, the common cold viruses, and also COVID, but also fungi, parasites, and fluid overload can cause this disease. And as we learned from this pattern, and as we learned from this case, also we should always think about drug toxicity as a diagnosis of exclusion, in this case of amiodarone-induced pneumonitis. Wasn't able to finish, or I was too fast ahead. So I wanted to put in some teaching points from my Anki deck, but it's a diagnosis of exclusion. It's like a 2% risk, and it mostly occurs in pre-existing pulmonary disease, and most commonly after 6 to 12 months after initiation of amiodarone, and presents with acute to subacute pulmonary syndrome with cough and progressive dyspnea. And yeah, you can do a BAL and you see these lipid-rich macrophages, which aren't pathognomonic and also not too specific, but can be a clue. You can also get a decrease in the DLCO. And the treatment is usually glucocorticoids if there is severe hypoxemia, like in this case. So thank you everyone for joining us today, and I hope you learned something. I certainly did, and I wish you all a nice day, evening, or morning.
Well, thank you, Sammy. That was great. I absolutely learned about amiodarone-induced lung toxicity, and I just will remember Deborah's teaching point, lipid-laden macrophages. So definitely we'll keep that in mind. All right. Take care, everybody. Thanks for joining. Have a great day. Bye.